Okay, this session we're going to address the objective examination of the lumbar spine. For the subjective examination, there's a whole other video, so please check that one out. Make sure that you've looked through that material as well, because really, as I said in the subjective examination session, that the subjective really directs the objective. But we want to talk about the components of the objective in this session so that we know what we're being directed to. And so today, or in this session, we're going to look at the anatomical structures that may be the cause of the problem. So we're going to look at joints. We're going to look at discs. We're going to try and differentiate between joints and discs. We're going to try and identify or look at the muscles that might be involved, the dermatomes and the myotomes that might be affected by the conditions that we face. There's a PDF of the slides of this session that is available for you to download. So hopefully you've got those. Hopefully you've printed them out. If not, pause the video at this point. Go print out the slides. It'll make things a lot easier to follow along with. Also, you can take notes. And if you have questions that come up as the lecture goes on, please jot those down beside the appropriate slide. So when we get together in our lab session, then you can either bring those questions to me then and we'll try and answer them for you, or you can email them to me to jason.craig@marymount.edu. So if you haven't got the PDF, go get it now. If you have got the PDF, okay, let's get going. So we're really looking at how we can plan the objective examination. We're looking at the most effective way to do that. We want to consider the pain that the patient is in. We're assuming that our patients have come in with some sort of complaint, some sort of low back pain probably. We've done our subjective. We've got a good understanding of the patient's perception of their symptoms, the patient's perception of their problem, and we want to figure out how we can effectively assess what causes that pain, what is being limited or affected by that pain, and how we can then organize and direct our treatment. And so that's what our objective examination is all about. We're going to consider the type or the kind of the examination that we want to take. Are we going to be very forceful in our examination? Are we going to push them all the way to the limit or to the edge of their range? Or are we going to be very gentle? If the patient comes in and they're very pain dominant, where their condition is just acutely painful, we're not going to force them into a lot of excessive range of motion tests. We might get very little of our objective assessment done in those cases. We might be just trying to find a position of ease where we can get our patient in to try and decrease their symptoms. And so we want to understand from our subjective where we go with our objective. We want to examine the underlying abnormalities. We are trying to identify the source of the symptoms. That's a key thing. We want to identify what's causing the problem so that we can treat the cause and not just treat the symptoms. We can certainly get symptomatic relief with most of our patients, where we just treat the pain or we treat the stiffness because that's their biggest complaint. But if we don't treat what's causing the pain or what's causing the stiffness, then we're actually not treating the problem at all. We're just giving them a respite before the next episode comes in and hits them. And so we've got to think about the purpose of our objective examination. And we're really trying to interpret the patient's concept of their disability into terms of joints or muscles, or in this case with the lumbar spine, the discs that are actually causing the pain. So we're taking what they're saying, their story, and we're going to interpret that anatomically and biomechanically into their body. We're going to determine physical factors that may have predisposed to the onset of the condition. We're going to continue with our hypothesis forming. We're going to continue with our acceptance or rejection or modification of that hypothesis, so that the hypothesis that we created as we were asking them questions and subjectively examining them, that now we've got the objective to really put meat on it. Does it really hold true? Do the tests and measures prove what we had thought? Sometimes we need to generate those new hypotheses. So where we have maybe missed something, where we've maybe taken something, and we haven't been able to to take all of the symptoms, all of the complaints that our patient brought to us in our subjective evaluation. We haven't been able to tie them all together. But then as we do our objective motions, as we do our objective tests, then we begin to really clarify that hypothesis. We want to reproduce comparable signs. Our patient has told us what their symptoms are. We're going to try and reproduce their symptoms. And it's vitally important that we reproduce their symptoms and not just create some other pain or some other discomfort. There's lots of things that we can do which can cause pain and discomfort to our patient, but we want to know about their pain. What did they bring to us? That's a key thing. We want to clarify our options for treatment. We want to select techniques that we're going to use based on what we have seen. And so the objective assessment and the subjective assessment go hand in hand. They work together to give us all of the information that we need to be able to effectively treat our patients. One of the aspects of the objective exam is provocation tests. Provocation tests and biomechanical analysis. In provocation tests, we're going to position or move our patient in a number of different ways to try and reproduce or to provoke their signs or their symptoms. Really, provocation testing is the underlying principle of both the Maitland and even the Mackenzie approach. It's not something that's just isolated to Maitland, but it's how can I make this worse? What motion can I do that's going to provoke their symptoms? It's kind of one of those things that gives PTs a bad name, because we're always asking, does that hurt? Does that hurt? Does that hurt? And patients become just confused. They think that all we're interested in is pain. Well, no, what they miss is that we're actually moving you in a particular pattern or fashion, knowing the biomechanics that are involved, knowing what structures are being stressed, and we're trying to elicit symptoms. And so when we go into our provocation testing, then we're really trying to gain valuable information on what is going on with that patient. This provocation testing versus the biomechanical analysis, well, Syriac's did a lot of provocation testing. And it kind of parallels modern US osteopathy. The theories that the osteopaths use in terms of motion and how does that affect symptoms. Provocation tests have been clinically proven over the years that we have a good level of reliability with them and validity. So that as we do the test, as we do the motion, we get the symptoms, we know what it means. And that's vitally important. One thing that we do want to try and differentiate between are the inert versus the active structures. And we're going to use things like isometric muscle testing for that. Contraction of a damaged muscle will cause an increase in pain. But if it's isometrically performed, then it's only the muscle that is being stressed. The joint hasn't moved. And so we've got an active tissue being the muscle. We've got an inert or an inactive tissue being the joint. We contract the active. We don't move the inert. We get pain elicited. It's got to be coming from the muscle. If we were to do an isokinetic contraction, so we contract the muscle and we move the joint and we get pain, we don't know which one it is because both have moved. And so we're going to use differentiation tests to be able to identify is it an active structure or is it an inert structure? Is that the site of the symptoms? Is that where the provocation is coming from? We're going to look at bony structures. Okay, we're going to look at the joints. We're going to see, are they being compressed? Are they being distracted? Is the motion passively causing the issue? Well, if we passively move a joint, then we're not incorporating the muscles. So the opposite is the case. We passively compress a joint, patient says that's painful, then it has to be the joint that is the problem. The muscles haven't been activated. And so we're going to use these differentiation tests. We're going to use active tests, active physiological tests, flexion, extension, all those sorts of things. We're going to do some auxiliary tests. We're going to check some neurological components as well through active testing. We're going to use passive tests. we're going to move some pain-sensitive structures. We're going to move some structures within the vertebral column. By using distal components, we're going to begin to move some of those neural components and see if they're the pain-provoking location. We're going to do passive physiological movements. We're going to use some palpation and, of course, our passive accessory glides to assess range of motion of individual segments in the lumbar spine. We're going to do postural observations. Every therapist loves postural observations. We're taught it over and over and over again in college. And yet, we skim through it really quickly. And so in our postural observations, we want to see how the patient holds themselves. And we want to do that in a couple of different ways. The first way that I'd like you to think about doing postural observation is as the patient walks into the clinic and they're not completely aware that you're watching them. You know, if somebody tells you that they're going to look at you, they're going to observe you, well, you kind of straighten up and you get yourself all presentable. But whenever you're not aware that you're being observed, when you're not aware that somebody's actually watching you and looking for how you're moving, then you're much more natural. You're just much more relaxed. And so any abnormal postures are going to be a lot easier to identify as the patient's just walking into the clinic or walking away from the clinic than whenever you sit them on the edge of the bed or stand them in front of you and say, okay, I'm going to look at you and do a posture assessment. Everybody shifts. So let's look at them before they get in to our little treatment area. But when we have them in the treatment area, then we're going to do our posture evaluation and we're going to look for specific things. Okay, we want to get our patients to stand as comfortable as they can stand. And we're going to look at all the levels. Levels of the ears, levels of the shoulders, okay, right the way down to the feet. Look at weight bearing. Is weight bearing even? Are they standing shifted to one side? Are they tilted to one side? What's going on? Are they way over here, way over there? What's happening posturally? We're going to look at them from the side. We're going to look and see, is their head protruded? Are they way back in retraction? Is their ear over their shoulder, over their greater trochanter? Do they have a large lordosis? Are they anteriorly tilted, posteriorly tilted? What postural observations can we take or gain from our patient and do those postural observations add to our hypothesis? Do they confirm it? Or do they somehow cause us to have to modify it? Postural observation is vitally important. Let's not just skim through it, but let's make sure that we spend the appropriate amount of time working our way through our postural observation. When it comes to our active tests, so we've brought our patients in and we've had a look at their posture and we've heard their story and we've talked to them and we've got our hypothesis going. And we're going to do our active tests. And we're going to do our active physiological movements. And in our active physiological movements, we're going to look at forward flexion. We're going to look at extension. We're going to look at side bending to the right, side bending to the left. And then we're going to sit our patients down and look at rotation. And we'll run through these in our lab day. If that's part of the course that you're signed up for, then we'll run through our assessment, our objective evaluation in our lab session. But in our active tests, we're looking to provoke symptoms. We're looking to identify, does it get worse with a particular movement? Does it improve with a particular movement? Are there quick tests that we could do? Sometimes we want to do some quick tests at the beginning just to try and clear some joints. Now, as you hear subjectively what your patient, their real complaint is, then you'll know whether or not you can do things like squat tests or single leg stance or heel raises, single legged or bilateral. If they're pain dominant, then we might never get to those. But if they're stiffness dominant or they're non-irritable, then we might be able to go in and do some of those active tests. But what we are going to try and do, pain or stiffness dominant, is try and go through our straight planar active movements. As we go into flexion, what happens biomechanically? Well, as we flex, slide the hands down the front of the thigh towards the knees and beyond, what's happening posteriorly is that we are opening up the posterior vertebral body joint. So we're compressing the anterior aspect of the disc. We're stretching the posterior aspect of the disc. We're causing pressure and force to push the nucleus posteriorly into the annulus. We're also opening or gapping the facet joints. And so as we go into forward flexion, what we're doing is we're gapping the facets, pushing the disc posteriorly. If the patient complains of pain, then one of those or either of those structures can be the problem site. But we don't know which one yet. All we know is that flexion causes pain. If our patient is pain-free, they go all the way down into flexion, no problems, no pain. Then we add some overpressure at the end of that just to clear that joint. A joint is considered to be cleared whenever it has pain-free, full range of motion, plus a little bit of overpressure. That's when we can say that that joint is not the problem. That movement, that motion is not the problem. So we'll do that for flexion, extension, side flexion. In extension, as we extend back, then what happens to the disc? The posterior aspect gets compressed. The anterior aspect gets stretched. The nucleus gets pushed forward. When it comes to the joints, the facet joints, as they slide into each other, then they get compression. So extension brings compression of the facet joints and an anterior force on the nucleus pulposus of the disc, which is the complete opposite then to flexion. So if our patients complain of pain on extension, the anterior aspect of the disc is pretty much devoid of any pain-sensitive fibers, so we don't get the same sensation if there's an anterior bulge as we do if there's a posterior posterolateral bulge. Most of the time when we have our pain with our extension, it's because of the compression of the joint surfaces. And so we have an opportunity again to look at a motion to try and identify the structure that's causing the symptoms. When our patients do these motions, we want them to be fluid. We're looking at the quality of the movement and not just the quantity. We're not just concerned that they can get all the way to their toes if it's a very jerky or a very staccato motion. We want the motion to be fluid as they bend down. We want to see, are the symptoms reproduced? Is it their comparable sign that we're getting? We want to know where in the range. If they go a little bit further, does that increase their symptoms or do their symptoms clear? Can they go further but they have this little arc of pain in the middle? If they're not performing the technique correctly, then we want to make alterations and correct them. If they're going into flexion but they end up doing a little sort of side swoop to get past a disc bulge, we want to stop them. Ask them to go straight. Well, I can't go straight. It's painful to go straight because that disc is just bulged in there. But if I go around it, then I can get all the way down. Okay, so we've got some trick movements, so we want to correct them. As I said, if the motion is clear, it's pain-free, patient will come back up again, go back down again, and apply some overpressure. Sometimes with our patients, we want to do repeated motions. Sometimes we want to do combined movements, where we get them to do multiple. A lot of times with extension, if it's a disc issue, I said that we compress the posterior aspect of the disc, we push the nucleus forward. Well, in the first instance, the first extension, a lot of times that just nips and compresses and pinches on that disc protrusion. But if you do repeated movements into extension, then that repetition actually will really encourage that nucleus forward and they can get a lot better. So the pain may go down with the repetition, and that's a good indication for a disc problem. If the pain stays the same with each repetition, then that's a good indication for a joint compression issue. And so we're going to look at our active tests. With the subjective, we've already determined whether or not we should move our patients to where the pain is just provoked or whether we want to move them to the limit of their range, regardless of where the pain is. If they're a pain-dominant patient, then we might just want to go to where the pain just begins to increase. We might want to stay in a pain-free range. But if they're a stiffness dominant, where they do have some pain and some discomfort in the joint, we might want to ask them, just go all the way, as far as you can go. What happens? Well, pain comes on. Okay. Can you go further? Yes, the pain comes on, and it only goes to 2 out of 10. Well, we don't think that that's too significant at this point. Can you go further? Does the pain increase? No, it stays at 2 out of 10. So it comes on, and it's just sore, but it doesn't really get worse. Those non-irritable patients, we can sometimes take them to the limit of their movement and not just to where the pain begins to increase. I've talked about overpressure. Overpressure is vitally important to be able to clear a joint, to be able to say that that movement is clear. We can't just do full range without symptoms. It has to be full range without symptoms plus symptom-free with overpressure. And so we want to then, that motion or that movement will then be recorded as normal on our charts or on our assessment forms. With repeated movements, as I've said, we're going to get our patient to repeat the motion that we've just done, but from the start. And we only really go into repeated movements if the initial planar movements were pain-free. If the patient goes down in deflection, oh, that hurts, don't ask them to do it again. It's probably going to hurt again. But if they go the full way down, no pain. Okay, can you just do that for me, let's say 10 times? And so they start to go down. Tell me if there's any change in symptoms. 1, 2, 3. Any increase? No, not yet. 8, 9, 10. Any change? No. Okay, so with repeated movements, we couldn't bring on. But why would we do repeated movements with something a joint that was motion that was clear? Well, if the patient in their subjective evaluation had said that they get pain when they sit, but it takes a long period of time to get on. It takes them to be sitting, at a hard back chair for 45 to 60 minutes. They noticed that when they had lunch one day, they were at a lunch engagement, and the chairs weren't terribly comfortable, and they were sitting for a long period of time, and their back began to hurt. Well, one motion probably won't bring that on. So we need to repeat the movement to try and get to that level of intensity where we start to get symptoms. So that's where we would bring in our repeated motions when we have cleared a joint through a planar movement. Again, without the subjective really dictating and guiding us where to go to, we would potentially miss that in our objective. With our repeated movements and with our planar movements, we, as the therapist, want to get into a position where we can see what's going on. Don't just ask the patient to do it and not look up from your chart. You have to observe the quality as well as the quantity of the motion. And so get into a position where you can see their back, where you can see what's going on. Look for the normal rhythm that there is during the motion. Sometimes whenever we're doing our repeated movements, we ask them to do 10, and they do 5, and it's sore. Don't get them to keep going. Well, I asked you to do 10, so the last 5 are just going to have to hurt. No, we don't want to get into that. What we want to do is we want to say, okay, just do 10 for me. 1, 2. Any change? Yeah, it's starting to get worse. Just stop. Stop where you are. Let's just reevaluate. So we've been able to provoke. We've been able to take our patient who had nothing on one single planar motion to now with repeated movements, now we're starting to get their comparable sign. That's what we're always looking for. Sometimes with our repeated movements, we want to test the upper spine on the lower spine. You want to see with this quality of motion, are they unwrapping and flexing from the bottom all the way up? Or is there a flat part and then they flex? What's the quality like? Where is the motion taking place? And as they repeat the movement, we can begin to see a pattern develop where they always keep the lower lumbar flat. They never flex those until the very end. Well, can we just change that? Can we get them to flex from the lower lumbar and then just to unwind the whole way down? You won't be able to identify that if you can't see it. So make sure that you're in a position where you can see what's going on. Sometimes when we ask for these motions, we'll see an abnormal movement. I already mentioned the disc. Patients with a disc bulge off to one side very often will kind of side flex around it. They kind of shift their weight around the disc as they move forward into flexion. And so with those patients, you should be able to see that abnormal motion. They don't want to go straight. They want to sort of skim around it. So look for those. Look for any deformities, any abnormal movements, particularly those that are provoked by or brought on by pain. Sometimes you'll see some protective deformities in the form of spasm, muscle spasm. That the patients will begin a motion and then they'll kind of get stuck there because the muscles have kicked into play. They're stopping the motion, and so you just mark the range, the distance that they traveled. The motion was limited because of spasm. A lot of times they can just be stiff. If they're stiffness dominant, then they're just not going to have the range. But they're going to be limited at the same location in the range. So if they can only flex down and touch the tops of their knees, that's as far as they're going to get. It won't hurt, but that's as far as they're going to get every time they flex into that position. We start with planar movements. When we don't get the results that we are expecting, we move to repeated movements. When we don't get the results that we are expecting in terms of producing the comparative or comparable sign, then we move it up a little bit more and we move to combined movements. And in combined movements, what we're doing is we're taking our straight planar motions and we're adding one to the end of the range of the previous one. So with a combined movement, we're basically taking and superimposing the compressive or the distractive forces on the joints by adding in subsequent motions. If you think about forward flexion, we take forward flexion and we bend all the way down. We open up the joints at the back. We gap those joints. Patient has no pain. Overpressure, no pain. Repeated movements, no pain. We want to make it a little bit more difficult. We think that this is a distraction issue. We think that this is a joint gapping problem. And so what we'll do is we'll take them into forward flexion to the end of range, and then we'll add side flexion. Side flexion compresses one side and opens the other side. And so in the side flex position, we've taken a joint that has been gapped, and then we have gapped it a little bit more. The key thing about combined movements is that we take them to the end of the first range, and we stay there when we add the second. Don't come back off of it and then add the second. Stay at the end of the first range before you add that second combined movement on. If we were to consider extension, a combined movement for extension, we go into extension. It closes down the facet joints. If we extend or side flex to the right, then we compress the facet joints on the right even further. If we come back up to neutral, extend, side flex to the left, then we compress the facet joints on the left even further. So we use our combined movement. So we gradually build ourselves up from our active motions of straight plane, repeated movements, combined movements. If we don't get any symptoms through all of these tests, then we've cleared the joints. We've cleared the movements. We've got to then start looking elsewhere for what is causing the problem. Most of the time, before we even get to combined movements, we'll have brought out the comparable sign. We'll have brought out the patient's symptoms through our provocation tests. Now, all these movements, according to Maitland, have been classified into patterns. And he has movement patterns that he's identified as normal and abnormal. And a movement pattern, basically the movement takes place at two joints, the facet joints, either side, left and right, and the interbody joints. So there's those three joints that are articulating, plus the disc. And so all of our motions, all of our spinal movements, all involve all of those structures. Both facet joints, the interbody joint, and the disc in between the two bodies. Now there's some regular patterns. There's some regular patterns of movement that I've already talked about, but let me just explain them a little bit further. The regular patterns are stretching patterns or compression patterns. And we think in terms of the joint. Think in terms of the facet joints. Facet joints sitting on either side of the lumbar spine are little synovial joints. They've got a little joint capsule around them, which means that they respond like synovial joints. When you move, you will move the articular surfaces relative to one another. You will either gap them, and you get a stretching, because what's stretching is the capsule, or you will compress those joint surfaces, and that way you are pushing superior and inferior facets together, so when we get a pain response from our stretching, it's typically a capsular issue. When we get a pain response from our compression, then it's typically a joint surface issue. It could be an osteoarthritic change. It could be something like that. And so we're thinking in terms of stretching, compression, stretching, compression. Those are our movement patterns. With Maitland, he described regular movement patterns, and of course, there had to be irregular movement patterns. Every time we have something that's regular, there's always somebody that doesn't fit the pattern, so they were irregular. And so we look at our regular movement patterns. Let's take a compression pattern. If we were to go into right lateral flexion, and we got right buttock pain, then what would happen is, dealing with compression, we're dealing with joint compression here. And so as we go into right lateral flexion and we close the joints on the right, we get pain in the buttock. We could also get that pain in the buttock if we were to go into extension, because extension is also a compression pattern. Now, if we want to make that pain worse, let's combine the movements. So let's go into right flexion, pain down the right buttock. Add in extension, which increases the compressive forces on that side. Pain gets much worse. If we wanted to check that that was a compression pattern, okay, then if we were to open that side by side flexing to the left and then to forward flex, there'd be no symptoms, or at least diminished symptoms, because we've gapped that compressive pattern. We've opened up the joints on that right-hand side that were problematic because of the joint surfaces being in contact. And so our normal compressive patterns compress through side flexion, add an extension, makes it worse. Our normal stretching patterns, just the same idea. Again, if we had right lateral flexion producing left buttock pain, well, we've opened up the joints on the left-hand side. We stretched those. We're putting pressure then probably on the capsule, irritating the nerve root, causing this radiating pain. Well, if we go into flexion, that gets worse. So we've got our compressive patterns and our stretching patterns in that normal or regular fashion. The irregular movement patterns are movement patterns that basically don't fit. So whenever we go into side flexion, pain here, and we add an extension, pain gets less, diminishes. That doesn't fit. It's a compressive issue. It should get worse. No, it's an irregular movement pattern. Similarly with the stretching side of things, okay, if you add stretching and you further increase the stretch, it should get worse, but it doesn't get worse. It becomes an irregular movement pattern. All of these tests, all of these motions are to help us try and differentiate down into location, one side versus the other, and then pattern, stretching versus compressing. Now when it comes to the compression patterns are joint. They're a joint issue. But a stretching pattern, we're not really sure. Is it discogenic or is it arthrogenic? Because in those stretching patterns where we're flexing, we're gapping the interbody joints, we're pushing discs posteriorly. It could be a disc protrusion. We're just not sure yet. So we're always holding those things in tension. But when it comes to the compressive ones, that's always joint surface. It makes life a little easier to differentiate. Other tests that we want to move on to, neurological tests. In our neurological testing, we're looking at the difference between signs and changes in signs. So our patient has all these signs that whenever they perform a particular activity, the pain increases or the tingling or the numbness increases. Well, we want to know how do those signs change with the motions that we do. And so we'll look at that through our neurological testing. One thing that we have to be mindful of is that your patient giving you the information is your greatest source, but it's also your most unreliable source. When a patient says, "Ow, that hurts," well, what has happened is that you've caused whatever compression or distraction to elicit pain. The patient then learns that you're basically going to do a number of tests to try and provoke pain. And the quicker that they say, "Ow, that hurts," the less you're going to actually do to them. And so sometimes you get some unreliable patients that give you unreliable signs. And you just want to clarify those. The good thing is that all of your signs should all match. So if you've got regular movement patterns, then they will all tie in. You get those irregular ones, kind of mucks things up a little bit. But most of the time, all of our signs tie together. With our neuro testing, okay, we're looking for those changes in signs. And we're going to take a note of the changes. We're going to take a note of the changes of loss of sensation or numbness or heat or tingling. All those things that are associated with our neurological testing. When we find that we've got neurological signs, then we want to assess the nerve roots. We want to assess the motion of the nerve roots. We want to look at dermatomes. We want to look at reflexes. And when we put together a lecture on neurological testing, you'll see all of the information on neurological testing in that lecture. We've done our active tests. We're going to go and do our passive tests, which is the second part of our objective examination. In our passive tests, we're going to move some pain-sensitive structures passively. So our patients aren't involved. They're not the ones performing the motion. We're the ones performing the motion. We're the ones that are going to move structures so that we can feel what's going on. We've seen what's going on with our objective active tests, and now passively we want to palpate structures as we mobilize and move different things in the vertebral column to see how we're getting responses. If we believe that we've got a compressive joint issue, well, we should be able to come in there and palpate and compress that joint by pushing the vertebrae together, and that should also elicit the same pain response. If we've got a distractive problem, well, can we distract the joints? Can we passively come in and open up those joints and be able to identify the exact level where that pain is coming from? So our patients have said they've got this right-sided pain. It comes on with a compressive pattern. Well, if we start at S1 and work our way up to T10, and we compress each facet joint, we're going to find the ones that are problematic. And it may be more than one. It might just be one, but it may be more than one. And we're going to do that all passively. We're going to move some pain-sensitive structures. We're going to move the dura. We're going to use things like straight leg raise, where in a straight leg raise, as we lift the leg up off the bed and we begin to flex dorsiflex the foot and the ankle, we really stretch the dura right the way through from sciatic nerve up into spinal cord. When we get into our passive physiological tests, we're really going to focus on the ones that were pain-provoking during our active physiological tests. We don't need to go and palpate every structure to try and ensure that, yes, these joints are definitely pain-free. We're looking for the ones that were pain-provoking in our active tests, and then passively we're going to confirm. And so again, we're still confirming our hypothesis. We're still adding in one or two more pieces to get that final confirmation. With our passive movements, and we're going to do a lot of this in our lab day, in our passive movements, we're going to determine the barriers that we hit as we passively take a joint through range. So as we mobilize, if we put our thumbs onto L3, patient's lying prone, and we were just to push straight down in a posterior to anterior direction, at some point down through that range, we're going to hit some resistance. Well, the first point that we find, which is resistance, we're going to call that R1, the onset of resistance. Sometimes we go down through and we hit pain. We're going to call that P1, the onset of pain. Sometimes we might get muscle spasm, S1. Sometimes we don't get to the end of range. We stop. We've hit a limit. And so we're going to look for those barriers. Because if it's a resistance, if it's a stiffness-based patient, we're going to hit that resistance. That's where we're going to mobilize to regain range. If it's pain, then we've got that pain-dominant patient. Then we're going to find out where in the range that pain comes on, what mobilizing techniques we can do, grade 1 or 2, grade 3s or 4, to actually get to treat those symptoms. We're going to use passive accessories. We're going to use passive accessory motions to then treat. We've gone from active to passive physiological to now mobilizing these joints into an accessory pattern to see if we can get that slide or glide that's necessary at those joints to free up and to clear it from symptoms. To move R1 further down in the range so that that joint isn't as stiff. To eliminate pain so that that joint isn't painful. And we're going to use our accessory glides and our mobilizing techniques to do that. With our passive accessory tests, we're going to take a joint through range. We're going to feel. And so we've seen our patients move. We've heard their story. And now we're feeling the range. We're feeling what the joint will allow us to do. We're feeling when the resistance comes. We're feeling when the pain comes. And we're building up a complete picture of what is going on with this patient and with this condition. We're going to test each vertebral segment. We're going to palpate. We're going to palpate from S1 all the way to T10. And we're going to move L5 relative to S1. We're going to move L4 relative to L5 and L3. And we're going to see if the positioning of the joints, if the motion of the joints causes pain. We're going to go all the way up through the lumbar vertebrae. We're going to assess any changes in temperature, any changes in soft tissue, any increase or eliciting of spasm that we get. We're going to feel for any bony anomalies. We're going to think through our fingers as we take our patient and take more information from everything we've seen, everything we've heard, and now everything we feel. We're going to check through passive accessory intervertebral movements, sometimes known as PAVMs. We're going to take each joint through range so that we get an understanding of how much motion should be available at each level. Because then whenever we feel a stiff one, it's really obvious. We're going to check the pain response that we get as we do this. Because if we've provoked pain through active movements, if we've provoked pain through passive physiologicals, then we're going to provoke pain through our passive accessories. And that pain then will guarantee us and confirm to us that our hypothesis is correct or that it's incorrect. So we've taken the story, we've taken movements, we've put together subjective and objective, we've taken a patient with a diagnosis of low back pain, taking them right down to a patient with a focused diagnosis of a compressive injury on the of the facets between L3 and L4, say, with compression of the joint causing then inflammation, which is affecting the nerve root between L3 and L4, which is then causing pain down into the leg. So we've taken the story and put our anatomical and our biomechanical knowledge to work to give us an accurate diagnosis. We talk about in the subjective examination that the diagnosis is not the be-all and end-all, particularly whenever your patient walks into the clinic with a diagnosis of low back pain. Well, that's not really very useful. But if the patient were to walk in with a diagnosis of L3, L4 joint compression with an inflammatory response affecting the L3 nerve root causing pain into the anterior thigh, you would know exactly what was wrong, exactly where to treat, and how to treat it. That's what we've achieved through our subjective and our objective evaluation. We're going to move the vertebrae. It's the last part of our passive accessory test. We're going to move the vertebrae at the spinous process. So we put our thumbs on the spinous process and take them from a posterior to an anterior direction. We're going to move the vertebrae on the transverse process, where we step out to the side and we palpate on the side. And we'll go to the other side. And so in that way, we're causing this rotation of the vertebrae, where we're closing down one joint, we're opening up another. Are we getting pain here with our compression? Are we getting pain here with our distraction or our stretching? All just from our passive motions. We might just step off the spinous process and just right down beside the spinous process are the facet joints. And depending upon the spasm or the softness of the erector spinae muscles, we might be able to get in there to the facet joints and really get a feel for that compression or that distraction. When it comes to the objective evaluation, we're going to be guided by our subjective in terms of the nature of our objective, the kind of exam that we're going to do. Is it going to be very aggressive or not so aggressive? Are we going to be very gentle? Are we going to try and complete everything? Or are we going to just kind of do what we can based upon the patient's pain responses? As we move through our active movement tests, and we listen to the story that the spine tells us as we flex and extend and side flex, does that tie in with our hypothesis? Or does that not? Does that mean that we need to modify our hypothesis? Change our thinking? When we passively then move our patients and we begin to assess their spinal motion through palpation, once again, are we confirming or are we having to reject our hypothesis? When we come together in our lab session, we'll spend time and we'll do this. We'll run through our objective test. And we'll look at all of the aspects of the objective assessment. And we'll try and tie this all together. We'll spend a lot of time palpating, a lot of time feeling, a lot of time moving and mobilizing these vertebrae. Because once we have our objective and once we've got to our diagnosis, then that really directs us as to where we go with our treatment. That really shows us what we can do, the effect that we can have whenever we start to mobilize. If you have any questions on anything in this lecture, then please contact me. Email me at jason.craig@marymount.edu. Or, as I said, write those questions down in your notes, and when we get together on our Saturday lab session, then please, let's talk about them then.